I'm going to walk you through really an introduction to lymphoma treatment options because there are so many. And so it is also important to acknowledge that, given where I work at Princess Margaret, we do a lot of early phase clinical trials. We get a chance to work on drugs that are very early in their development. And so for that reason, you have to acknowledge that you've worked with a number of companies that have been involved in helping bring some of these treatments into the clinic. So a couple of general comments here that I think are very important because we use a lot of terms, or people increasingly use a lot of terms that I think are not entirely accurate. And so the first one here, people are very excited about this concept of personalized medicine, right? So what does that mean? You saw Reshmi give you a presentation where you show how much work can be done on an individual tumor sample, how much work can be done now to look at specific genetics, specific mutations in a cancer cell. And in lymphoma and in oncology in general, we have many drugs that can target specific mutations, yet we're not using those routinely in the clinic. And so, we can say we modify therapy for specific types of lymphomas, specific subtypes within specific diseases like follicular lymphoma, potentially based on grade or potentially the type of diffuse large cell lymphoma that you're treating. But this is not truly individualized to reflect individual mutations. That comes with a different layer. It is yet to be proven in most cancers that that's actually of any benefit as part of the primary treatment of a cancer. But we will see those studies done, certainly over the next several years. But will it work? That's one of the big questions that the field is trying to answer. I've highlighted the second point already. We always are constantly balancing toxicity versus effectiveness of treatment. And again, with chemotherapy, the example is obvious. You can give insanely high doses of chemotherapy that people can survive. The question is more better? And so does dropping an atomic bomb on something, is that really the right answer where, we're stressing the idea of precision? And I'd argue here that generally, even though, sometimes it's human nature to feel, if I'm being beat up more, this is going to be ultimately good for me, no pain, no gain. That's often not true in the world of cancer, where effective therapies now come with very manageable side effect profiles. The final point here is maybe a conversation you've been a part of or will hopefully be a part of sometime in the future, the question of what remission means versus what cure means, okay? And so technically it's very difficult to ever tell someone they are cured because you don't know the future, right? And a lot of this is based on probability, right? You heard about Shannon talking about, we measure likelihoods. Young people don't tend to have most cancers, right? So your pretest chances of finding a cancer in a perfectly healthy 20-year-old are much different than someone who's older and has a lot of other problems. But so remission is when you have a series of tests done in a cancer and you can't detect cancer within the limits of whatever testing you're using. A PET scan, a bone marrow biopsy, a set of CT scans, blood work, whatever it is. But that's a snapshot of one day. And we know even if we may not detect a cancer, we don't have the technology to detect a single cancer cell, right? No one does. But we know that if you're in remission, if you have a curable disease, that's the best single situation you can be in. And if that remission is maintained over time, you'll be cured. All right, so cure is remission that's just maintained forever, at least until someone dies. We don't know when that's going to be. But the likelihood of this, so the day after you finish a treatment, you're in remission, best place you can be. If you're in remission 5 years after you've finished treatment, again, the probability, because you've stayed in remission for 5 years, is such that for most aggressive lymphomas, the likelihood of it coming back after 5 years is very low, and thus we start to use the word cure, and that's where the 5-year mark came from. Okay, it's just probability looking at if you looked at thousands of people with a cancer, the likelihood of it coming back gets lower and lower and lower with every year that this goes on for. Unfortunately, it's not perfect because we do see recurrences even at 10, 20, 30 years. But again, the vast majority of the time when you get to 5 years, things generally go well, at least if it's a type of lymphoma that can be cured. A little point about treatment philosophy. So that classification of lymphoma that generally now has, over 60 different subtypes, in the clinic, we functionally think about two types of lymphoma based on the behavior. So an aggressive lymphoma can be generally treated with curative intent because these are diseases that can be cured with standard approaches. And so when you have the opportunity to cure somebody, I think we're all willing to accept, again, maybe a little more toxicity, maybe putting someone through something difficult, maybe a bone marrow transplant, et cetera, in order to achieve that goal. But in a disease that you can't cure, and if cure is the most important thing we can accomplish in cancer, then what are the other goals here in terms of how we think about treatment? And again, this is the stuff that people think about when they're deciding treatments, and these are the things that hopefully you can have meaningful conversations about with the clinicians that are looking after you, because there are other important things. So if I can't cure somebody, but if I have a treatment that can make them live longer, if I can improve survival, that's the second best thing we can accomplish. And I would say we're also willing to occasionally make people sick in order to accomplish that goal. Okay, if we can improve quality of life, so if you have symptoms of your cancer, can we make them better? I mean, there's no doubt that that's a good goal to accomplish, but think about that. So if your quality of life is the goal, if the treatment makes you sick, is that actually the right answer? So logically it isn't if the toxicity of the treatment may be worse than the symptoms that the disease is actually causing. And that's why in certain circumstances, if a treatment isn't curative or can't be shown to improve overall survival, we may not say a very tough treatment like a transplant or a very complicated chemotherapy is worth going through if it makes you more sick than what the disease is actually doing. In contrast, so in indolent lymphoma then, one of these things that comes up as a question frequently is this idea of observation. And that comes exactly from the points that I just mentioned. So in a disease, when you can't cure it, if someone's asymptomatic, that's the reason we don't start treatment. We know treating asymptomatic follicular lymphoma does not change how long a person lives by a day, but we know that treatments can cause side effects. And so that's, again, the philosophy of approach here. And again, 3 very large randomized studies have looked at that question historically with chemotherapy, a few more with more modern treatments like Rituximab. None of them showed that you lived a day longer. And if you're exposing people to risks and side effects without making them live longer and without improving quality of life, I'd argue there's no point in doing it. Okay, but very important concepts behind the decision-making that's going on in the clinic. All right, so the next few slides really highlight, various classes of treatments that we give and just probably set the stage for a lot of what you're going to hear about through the rest of the day. So not the most exciting stuff, but I think important from a treatment 101 perspective, if you want to look at it that way. So chemotherapy is the original bedrock of treatment in the field of lymphoma. Most chemotherapy works through damaging DNA in cancer cells. That being said, it's not targeted, and thus any cell that's growing, and cancer cells are felt to be the cells that are growing the most quickly in patients, so they'll all be affected by this. So when you think about the standard side effects that we see with chemotherapy, they're because we're damaging normal living cells as well. So lymphoma cells, again, are growing and can be affected, but the cells in the bone marrow, so producing normal blood cells, so that's why neutropenia develops, so white cell count goes down, leading to risk of infection, typically 5 to 7 days after chemotherapy starts. The lining of the GI tract, so again, that's where we can see nausea, mucositis, diarrhea. Hair cells constantly growing, which is why for many of these treatments, alopecia during treatment can be a common side effect. Chemotherapy, though, is a systemic treatment, right? So it can be delivered subcutaneously, orally as a pill, intravenously typically, and so because of that, it can go anywhere the bloodstream can deliver it, and thus can be a very effective therapy when cancers can affect blood cells, and we know by its nature, lymphomas often spread. Just to make a little point about terminology, many of us use chemotherapy interchangeably with this concept of a treatment that is systemic that treats cancer, so an anti-cancer therapy. I think to be a little more precise, again, this is what we're talking about. Rituximab is not a chemotherapy in the true sense of the word. It's targeted, it doesn't work through this type of mechanism, and it's another class of agent. It's what we call a monoclonal antibody. Okay, but again, some of the precision around that when you're providing information to patients may not come across that way. But if it comes up as a question, ask the people looking after you, and they can provide those distinctions when explaining treatment to you. So again, as treatment evolved historically, a stem cell or bone marrow transplantation is one of the next kind of concepts that came up. And again, the purpose behind this initially was around the principle of delivering high-dose chemotherapy. And so an autologous stem cell transplant, which is still the most common type of bone marrow transplant done in a patient with lymphoma, is just a vehicle for people to be delivering very, very high doses of chemotherapy. Lymphoma in general is typically a chemosensitive disease, and so the idea here, which was proven in a lab, was that if you give very high doses of chemotherapy, you can overcome drug resistance in a non-specific manner. And so the problem, the fallout from giving high doses of chemotherapy here, the side effect was you wiped out normal blood cells that would not be able to then recover after this, but we've collected normal stem cells or normal young bone marrow cells from a patient, been put away in a freezer, and after the chemotherapy is no longer measurable in the system, which is usually 24 to 48 hours after the chemotherapy has been given, those cells are taken out of the freezer, they're thawed, they're given back to a patient just like a blood transfusion, and then over the next 10 to 14 days they find their way into the bone marrow, and they set up shop and they repopulate your normal blood system. An allogeneic stem cell transplant, so the twist here is that not only is chemotherapy being used to help to get rid of cancer cells, that may not be the sole purpose. So the other thing here, the cells are now coming from a donor. They could be a matched brother or sister. Now it may be a matched parent or child. It could be an unrelated donor on a registry. And now you're getting a new bone marrow system, but you're also getting a new immune system. And so here, in this setting, again, replacing a bone marrow system when the bone marrow system itself is sick makes a lot of sense in a disease like acute leukemia or an acute myeloid leukemia, where the bone marrow is the problem. Those normal cells have been replaced by abnormal bone marrow stem cells. In lymphoma, the new bone marrow system also comes with that new immune system. And as a cancer of the immune system, that's what lymphoma is, perhaps replacing the immune system is a good concept. And so historically, that was the one way that we could do this. That being said, you're going to see the last session in the day, immunotherapy with Dr. Foley. We now have a whole new series of tools, antibodies, bispecific antibodies, pills that can target specific signaling pathways in immune cells, and now we can engineer cells again and turn them on and make them more effective. And so this is really where that's going to go. And so I think what you're going to see over time is we're going to start to see less emphasis on transplantation approaches in relapsed and refractory cancers, and we're going to see some of these very novel, elegant treatments in time hopefully replace this, because ideally they may be ultimately more safe and more effective. The work is just being done. So I'm going to show you a couple of the common chemotherapy regimens that we use just to kind of give you a sense of things. And a lot of this just evolved based on, again, clinical trials that were done in patients, demonstrating safety, understanding side effects. And you'll see things are given in slightly different ways based on the drugs and the doses that are being used. So ABVD is an interesting one. It's been around for a long time. So it's a 4-drug combination, as you can see, with drugs at that dose. It's one of the few regimens that we use in lymphoma that's confusing in terms of how you count it. So there's an A part and a B part. They're given 2 weeks apart, and those 2 treatments make 1 cycle of therapy. Okay, and so it's technically a 28-day program, but you're giving treatment once every 2 weeks. You may see in contrast, so CHOP is again a very common regimen that we use potentially with Rituximab in B-cell lymphomas, or without Rituximab in other types of lymphoma like T-cell lymphoma. But you see some similarity in some of the drugs that we use. So that drug adriamycin or doxorubicin, that's a red drug that you might have received. So this is perhaps the single most or the second most important drug that we use in the treatment of lymphoma. And again, it's a drug that's been around for a long time, but again is one of the backbone drugs for 2 of the most common curative treatments that we use. Again, in contrast, this treatment's given every 3 weeks. So what's that difference? Why 2 versus 3 weeks? It's actually because that's how long it takes for your normal blood cells and other side effects to resolve before you can get another treatment. And again, a lot of these treatments were then developed before we had additional supportive drugs, so drugs like Neupogen or Grastafil, drugs that can accelerate blood count recovery, which then lead to questions about could you change the schedule? Could you give these drugs in shorter treatment intervals? So not surprisingly, that's been tested, and just shortening the interval and giving chemotherapy more quickly, you might think it makes sense because the cancer may not recover as much from each treatment, but that actually hasn't shown to have been of any advantage, though it has been tested in a number of studies. And then a drug that's given monthly is this drug Bendamustine, which again is one of our backbone drugs in non-aggressive, so indolent lymphoma, diseases like follicular lymphoma. Okay, a couple of comments about radiotherapy. When do we think about radiation in lymphoma? So certainly the concept is if you have a localized lymphoma, 1 or 2 sites, radiation's a local treatment, and so it's potentially quite an effective therapy in that setting. We don't use it in all types of lymphoma. We certainly don't use it in all types of aggressive lymphomas, but it is a very important treatment that's been around for a very, very long time. The way it's given, unlike chemotherapy, is radiation's a treatment that can be given every day. And we sometimes give it as 2 doses in non-aggressive lymphomas. It can be given for 20 doses or potentially longer, depending on the schedule. The difference with chemotherapy is that when you think about how the side effects come up, radiation is a local therapy, so just imagine the side effects are going to be based on where the radiation is given. So, radiation to something on your arm is going to have very different side effects than radiation that's being given in the chest. The other concept here that's very important, not all radiation dosing is the same, just not all chemotherapy dosing is the same. So the radiation dose that someone may use in a head and neck solid cancer is about twice as much as the dose that we use in a lymphoma. Lymphomas are generally much more radiation sensitive, and thus you can't really compare notes if someone's getting radiation therapy for, again, a head and neck cancer, because the side effect profile there is likely to be much more significant than a similar lymphoma patient who's getting radiation therapy. So, as an example, these are the types of radiation fields that we may use. So on the left of the screen, that's a PET scan image, so the area that lights up was active sites of disease in a patient. And you can see predominantly here on the neck, but then starting to extend down, and the area here is right on top of the heart. And so the concerns, and this is why the radiation oncologists have a ton of very, very experienced and well-trained staff to work with them, because you can see a lot of modeling goes into this in terms of simulating where the radiation is going to be given to help minimize the risk to normal tissue. So again, you heard some comments earlier about radiation potentially affecting the thyroid, but in this area, there are a lot of other important structures that they learn how to protect. And so there's a lot of art and science that kind of goes into doing this to minimize risk to healthy tissue, including, again, the heart, potentially the breast, to think about other risks that we all worry about, be that secondary cancers or potentially accelerating heart disease in people as we get older. And so potentially here, you can see the difference. So this is another patient with Hodgkin's lymphoma, but you can see compared to this person who has a lot more disease, the amount of disease here is much more localized, and you can see, given that radiation planning field, the risk in terms of radiation to potentially normal tissue is a lot lower just because there's less disease at the baseline. And so this is certainly going to be a safer plan with a lot lower risk. So these are the discussions that we'll have when we think about the approaches to treatment that we're giving. And so again, we're lucky in bigger cancer centers to have the opportunity to sit down directly, the radiation oncologist, the hematologist oncologist, often the pathologist, often with our radiology colleagues, to really put that whole story together to come up with ultimately the best treatment plan. A lot of these things are also response adapted, and so I think that's the other thing that we have to struggle with, because when you sit down in the clinic and talk about the initial treatment plan, so if there are any of my patients here, you've heard me say, we'll see how this will go. This is the sketch, but I don't know what your scan's going to look like midway through treatment. I also don't know what it's going to look like in the end, and that may influence the how and why about what we think about with things like radiation, as well as the feasibility and what the risk profile may look like at that time. And so that's a very important point. The other thing I would say, without dwelling too much on the technology issue, so we have a tool that adds on to what we know about CT scanning. So PET scanning is still relatively new in Canada, but it's been around for 10 years now or so. And we now know that in some patients where we're worried about radiation, that if a PET scan is normal at the end of treatment or midway through treatment, it may be more safe to omit radiation as part of a treatment plan. Okay, very complicated decision making, because we know in general when radiation is given, that still provides the most likelihood for cure. Okay, that needs to be balanced against the risks of the radiation and the magnitude of the benefit for the radiation. And so a lot of the decision making about how the pictures look and how the response has been with treatment become very critical in making those individualized decisions. So here's the comment about Rituximab. So again, Reshmi showed you how this can be looked for both on flow cytometry or both with the immunohistochemistry as well. So one of the important things to think about these types of targets for treatment, so a lot of those things that Reshmi was showing you are all on the cell surface. And so that means if they're on the cell surface, you can target it with something external. And so this sort of has an intracellular and extracellular component. One of the things that was known about it very early, as we talked about, is that it's mentioned on a variety of mature B lymphocytes. So for people with B-cell lymphomas, it's a natural target. But people still aren't entirely clear about what the function of this target is. So like many things in medicine, we now have an effective therapy. As to how it delivers exactly what it does, still not entirely clear. So this is the study that led to the approval of Rituximab initially in diffuse large B-cell lymphoma, a trial that was led in France and done in older patients with diffuse large cell lymphoma. And again, when we're talking about cure and benefit, so this was a treatment that improved the cure rate in diffuse large cell lymphoma by about 15% in everybody that got the drug. And when you think about that, that's one that is a pretty easy win. The benefit of the drug in terms of side effects was also really good. So this wasn't a drug that tended to cause a lot of side effects when it was given beyond infusion reactions that were typically mild when getting the drug. And so it factored in really well. So not a lot more toxicity, a huge payoff in terms of improvement in overall survival. And at the time, it might have been considered an expensive drug at about $3,000 a dose. But given the current landscape, when you think about it, it's become an incredibly cost-effective treatment moving forward as well. And again, that's the lens that all these drugs get measured in 2019. Just to shift gears, Bendamustine, so again, the chemotherapy that we use the most in follicular lymphoma and other types of indolent non-Hodgkin's lymphoma. So this was the trial that led to its approval initially as the primary treatment in those diseases. And what you can see here is that the time in remission with this drug was over double when it was compared to a standard chemotherapy regimen, both given with Rituximab in indolent lymphoma. So again, it didn't show an improvement in overall survival, but in this case, improving time in remission by doubling it. And again, it wasn't a particularly expensive drug. The side effect profile was better than the treatment it was compared against. And so again, when you add all of that together, that's what led to the approval and use of this drug in that setting. The point about maintenance Rituximab is here, again, the study that led to its approval in follicular lymphoma, and you can start to see a huge benefit here. And now the follow-up of this study still shows that about half the patients continue in remission after only getting that 2 years of maintenance at 10 years after completion of primary treatment. And so, again, when you factor in all of the benefit versus the slight risk of infection in this population, that's, again, why so many people have adopted it as a standard. So how do you improve antibodies? So here's an example of one of those treatments. So again, in the pathology section, Rashmi mentioned this target CD30, that can be found on certain subtypes of non-Hodgkin's lymphoma and frequently expressed in Hodgkin's lymphoma. So the story here is, again, CD30 sits on the outside of the cancer cell, so imagine the Hodgkin-Reed-Sternberg cell, and the antibodies given binds to that marker on the outside of the cancer cell, and then it's taken into the cell. When it's taken into the cell, a very, very potent chemotherapy agent has been attached to that antibody with a linker. The linker is chopped, the chemotherapy is released right into the cancer cell directly, and then it kills the cell. And so obviously you see the potential there to target the chemotherapy to the actual cancer cell of interest. And so the potential then to deliver a much more potent drug than you could intravenously straight to the cancer cell, conceptually you think it should work. So one of the studies that led to the approval of this drug was to give it in patients who are at high risk for having the Hodgkin's lymphoma come back after a stem cell transplant. And again, here, the top curve are the patients that received Brentuximab. And now, again, with 5 years of follow-up after this study, you can still see that difference between those curves. And, I would argue that means those patients who are 5 years out after having received this drug for a year post-transplant, their cure rate has been improved by, again, that difference of about 10 or 15%. So that has led us to one of those interesting places in Canada. So this is a treatment that has been approved by Health Canada. It is not currently funded in any other province except British Columbia. And it's this evidence, and the question is, given the cost of the drug, which is a level up from Rituximab, is the magnitude of that benefit worth it? And I think that's the question. As someone who treats Hodgkin's lymphoma, I would say that's a no-brainer. You're increasing the proportion of people that could be cured with a disease that otherwise they would then be incurable. So I'd say there's a lot of value there, but these are the types of issues that our system is kind of having to deal with. And here's the other study that's been done looking at Brentuximab as the primary treatment of Hodgkin's lymphoma. And what you can see here is, unlike that 15% benefit that I showed you with Rituximab in large cell lymphoma, the benefit here in Hodgkin's lymphoma is about 7%. And also, there were more side effects with this drug when it was given as frontline treatment. Higher risk of fever on chemotherapy, potentially a higher risk of infection. And so as the magnitude of the benefit drops and the risks start to go up, again, the slam dunk example was Rituximab, which is now 15 years ago or longer. But here, a more expensive drug, the benefit's a little smaller, the side effect profile a little worse. And so that's what we're all struggling with in terms of trying to continue to provide new and effective treatments. And again, here, so around the 6% or so benefit difference. One other antibody to talk about, and so we are seeing second-generation versions of drugs, and so Bendamustine, as some of you may know, is a second-generation version of Rituximab, and so it's been engineered in a way to be a more effective antibody. And so again, these types of antibodies in part work by working with the immune system of the patient to kill cancer cells. And so this was engineered to be a little more effective that way, and engineered a little bit more to kill cancer cells directly. And so again, one of the studies that looked at the benefit here, so in people who were refractory to Rituximab, Bendamustine, when given in combination with chemotherapy and then followed by maintenance, has been shown to improve overall survival. So in this setting, the drug's been approved across Canada and is now funded. So to summarize, so I've kind of thought of all those things, antibodies, as being standard therapies. And so the idea here, we have very good chemotherapy packages in these diseases, CHOP, Bendamustine, or ABVD, given on the type of lymphoma. We now appear to have useful antibodies in all three of these diseases. Again, Rituximab in non-Hodgkin's lymphomas, Brentuximab in Hodgkin's lymphoma. And so you've kind of seen how over 15 years, antibody-based therapy in combination with chemotherapy has really become a standard in these diseases, largely because more people are cured, the improvement in overall survival in diseases that we don't have curative therapy. Just to talk on a couple of things really quickly. So Dr. Foley at 4 o'clock is going to talk about this, amongst other things, in immunotherapy. So CAR T cells are something that you've seen a lot of in the newspapers, and it appears to be a very exciting and very active treatment. Again, the principle, so very similar to an antibody, the idea here is you want to target something on the cell. So this targets CD19, which like CD20 is expressed on B lymphocytes. The difference here is this is now on the outside of a T cell, so one of the immune effector cells that's available in a patient or normal human to help fight cancer cells, infection, etc. And what's been done in this case is the other modification is that they've introduced into the cell a number of signaling domains which ensure that the cell is primed and turned on to kill. And there have been some very excellent preliminary results. These are now approved by Health Canada to treat large cell lymphoma in a refractory group of patients, as well as ALL, typically in kids and up to the age of 25. But I think we're very close across the country to have this available as a standard of care treatment. And so I know Ronan will be doing a lot of discussion about that moving forward. Okay, so in the last couple of minutes here, I think what would also be useful, because I've spent some time highlighting a lot around clinical trials and research in lymphoma, to maybe talk to you a little bit about this. So I did meet someone in the room today who has been on a research study in my building with one of my colleagues. But I think it's important for, patients are obviously one of the most important pieces of clinical research. It's why we do it, but also, how we do it is with patients as partners. And I think it's really important to look at why and what we can learn. So a little bit of terminology here. So translational research, the idea here is taking findings from the lab to the clinic and back, potentially. And again, drugs like Rituximab clearly came from translational work that identified a target, had an antibody. Antibodies are normally made in the body, and so it was to copy an idea of a normal system that then could be used to work against cancer. Clinical research itself is asking specific questions that relate directly to patients. So it could be about drug effectiveness. So again, a lot of what we do is about trying to make therapy better. It may also be to show that we shouldn't be doing certain kinds of treatments anymore as well. Is it looking at specific subtypes of lymphoma? Again, you're seeing more and more lymphoma, different types, different subtypes genetically, and so we need to better understand how those people are doing. It can be looking at quality of life questions. It can be looking at therapy delivery. Many, many things you can look like. Why do we need more treatment? Well, I think it's obvious. None of these treatments are perfect. Even if they're 100% effective, we can still work on improving side effects, right? So I think there are many things here that can be done, but often what we focus on is this concept of drug resistance or therapeutic resistance. And going back to the well to use the same tools, if chemotherapy, as we talked about earlier, generally works in one broad mechanism, then looking to take advantage of different tools is really going to be the new approach that's going to be hopefully the most effective. And again, antibodies are a good example of that, and now we're maybe seeing cellular therapies that are hopefully going to be another step forward. A couple of words then about evidence levels and design of clinical trials and where they are in development. Okay, so you may be approached about anything from a phase 1 to a phase 3 or phase 4 clinical trial. What does that mean? Okay, so at the phase 1 level, this is looking at a question of, is a drug actually safe to be given to somebody, and can we identify the right dose, and what are the right side effects? So this may potentially be the first time that a drug has ever been given in a human. And so you have some ideas based on preclinical models or animal studies what the side effects may be like, but you don't know what these are going to be like until they're actually given to somebody for the first time. Another type of phase 1 study might be taking a drug that already has a well-established purpose in another setting, but you don't know how it works in a different type of cancer. Or it could be a combination of two drugs that are being used for the first time, as an example. So not all phase 1s are the same. Some of them may come with drugs that are well established in terms of their safety in other settings or their effectiveness in other settings, but you're still trying to get at a question where there are a lot of unknowns. Phase 2s are largely about how effective is a drug, or if you understand some of the side effects, how frequently do they occur. And a phase 2 is usually the deciding point between taking a drug forward or not. Do you actually ask what for us is the ultimate question, a phase 3 study, where you try to compare a new treatment that looks very promising against a standard treatment. So all of those curves I showed you where we were comparing two treatments, those are phase 3 trials. And so they're typically, as I said, randomized. So half the people in the study get the standard treatment, half of them get an experimental treatment. In some of those studies, they may be blinded, so we don't know who's getting what treatment. That doesn't frequently happen, but can happen. In some cases, they may be placebo-controlled, so you may not actually know if you're getting, even if you're blinded, we may not know if you're getting the study treatment or not. So all of that, you will know all of the characteristics of that study before you get into the trial, or as you're offered it, as part of the consent process, all of that will be discussed and it will be very clear. Typically, the other studies before that, a phase 1 or a phase 2, you will always be getting the study intervention. You'll know exactly what you're getting because there's less bias in what we're trying to understand. We're just trying to understand how effective it is. We're not trying to compare it against something else. How does evidence guide practice, right? Like, so again, for the people that have to review data and make decisions about how money is spent, they want the best level of evidence available. And so I'd show comparing 1,000 people getting one drug versus 1,000 people getting another, you can be fairly confident in the precision of the decision you're making. That being said, how do you do that in very rare types of lymphoma where you may not be able to find that many people to ask that question in that setting? Or what do you do in a setting where there is no clear standard effective treatment? And so what we've seen, in the past 10 or 15 years in the cancer world, drugs are increasingly potentially approved on smaller studies in places where people no longer had effective treatment. And in some jurisdictions, particularly in the US, the FDA is increasingly comfortable with that. But in other places, in Europe or the UK, or even in Canada, the people that make those decisions are still having some struggles with it because there are experiences where drugs that are initially approved, when they go on to bigger studies, don't ultimately meet the bar. And so there becomes a big balance there between needing to get what we think are very important treatments to patients quickly outside of research studies, but a little bit of caution about trying to ensure that what we do is actually the right decision and that we're not bringing risky treatments or ineffective treatments or hugely expensive ineffective treatments to people, which is what we really want to avoid. Our clinical trials for every person, I think the short answer there is no. Certainly you have to be willing to take some uncertainty because we don't know how things are always going to perform. We don't know how effective they are. You need to have a study that's actually open and one that a patient fits all of the checkboxes, the inclusion criteria for. And fundamentally, a patient needs to be interested in it. And I think that's a very, very important point. The thing to remember, though, is that clinical trials are designed to answer specific questions, right? So they're not really specifically designed to make patients' individual treatments better. And those are two different goals, okay? At the end, if a treatment's really effective and you got it, then that was a great thing for you. But we never know that with a high degree of certainty going in, okay? And so that's really important. Why do standard therapies vary from place to place? It's how people interpret those data and how people make decisions around how to best use them. So you can see country to country, we don't do things exactly the same, even though we have the same evidence to look at. Province to province, it doesn't happen. Sometimes in the same hospital, there are different nuances to why one lymphoma doctor may prefer one treatment to another. And a lot of it goes into interpretation of the data and then trying to apply it specifically to a patient. So that, I guess, is a little bit about personalization, but I would still argue that's more individualization than personalization. But if the signal's obvious, if you see survival advantage, if there's very little side effects, particularly if it's cost effective, it'll be easy. One more comment maybe on clinical trials. I'm coming to the end here. Why don't clinical trials run everywhere? You need a huge infrastructure in order to do it. You need lots of expertise in people, nurses, pharmacists, data coordinators, not just investigators that look after patients. So big hospitals have the setup to do that. Smaller centers don't. The good news is that there's open relationship in Canada and Ontario with streaming people to the right places to get the right studies. And so I think that is really important. It takes a lot of time and effort, it takes a lot of work, and it takes a lot of open exchange of ideas moving forward. And so with that, in 2019, you can just see, this was a quick snapshot to tell you that there are a ton of lymphoma therapy options that are available. Older standards like conventional chemotherapy and radiation still clearly have roles, and so we never want to forget that there are, again, hundreds and thousands of people that have been cured with those types of treatments, as well as with stem cell transplants. And so there will still be a role, even though we're all hopeful that these newer things can continue to find the right groups of patients to treat, so we can avoid needing to use these things when they're going to be less effective. The newer therapies that continue to come will head down these themes of personalization and immunotherapy, and that will all need to be done through clinical trials. And I think that's where we still have a lot of opportunity. And again, we'll continue to try and bring new therapies to have them available for patients in Canada. So with that, I'll close, and Liz, if we have time for maybe one or two questions, I can take them. So thank you.
I just have one thing to mention and a wish. So the one thing to mention is that I've talked to so many patients who are not aware yet, and I know you all know everything, but they're not aware yet of the relatively recent blood test that you can get through the hospital, through your oncologist, that determines how responsive you actually are to chemotherapy. So for me, for example, I'm not responsive to the traditional IV chemotherapy, which is fantastic to know because, not so long ago I would have gone through all of that treatment and with no benefit. So that's just the one thing I just wanted to mention. And the second thing is just a wish is that for anyone newly diagnosed with CLL, I just wish that I'd known all of the symptoms that we don't really talk about. Is that, like, there's only a narrow lens that the oncologist, I find, is, which I understand, is interested in terms of assessing whether I'm more aggressive or not. But I've had so many alarming things that are so-called temporary, 2 months, 1 month, 2 weeks, that don't mean I need treatment. That doesn't mean I'm getting more aggressive, but I had no idea. So anyways, if anybody's newly diagnosed with CLL, I could chat with you, but that's been a long learning process.
All right, so a couple of points there just for clarity. So the blood test that's being referred to is a test specific to CLL, which looks at a biomarker that predicts for how the disease will do if people are treated with standard chemotherapy. And so at the moment it's being used potentially to have novel therapies like ibrutinib potentially preferred as a frontline treatment. So while that is a useful tool in CLL, that does not apply at the moment to any other disease that we treat, okay? And unfortunately, no blood test is perfect, okay? And so, you could see from the number of markers that Reshmi showed you earlier, every disease, we're all working to try and find specific patterns or markers or predictors that we can identify when standard therapies aren't going to work and stream people towards novel therapy. That's certainly the goal. The second comment, I guess, about symptoms, so I think, we've done a little bit of a disservice when we spend a lot of time focusing on symptoms like B symptoms, so drenching sweats, fevers, night sweats. They are not present for the vast majority of people with lymphoma or CLL. When we see those are usually associated with a very specific pattern, very aggressive lymphoma, growing very quickly. Typically, they all come together, okay? So the other symptoms that come up here, as you could see, based on when you look at the sheer variety of lymphomas, it may range from very non-specific to asymptomatic to, again, a series of things determined on where the lymph nodes that are growing are located. So what it means in the end, unfortunately, is that you kind of have to take an open, an open form of questioning and really try to understand what's going on. Most of the time, patients are complicated. If there's more than one medical issue, there may be background medical issues, there may be drugs that can cause side effects. And so teasing out the specifics there, for any clinician are really the challenge, whether it's someone working someone up for diagnosis, someone deciding when the line tips between symptomatic and asymptomatic to recommend treatment for a patient, but also someone on chemotherapy where you're trying to understand what's a side effect of treatment, what's disease that may be getting better or worse. And that takes, a lot of time, which is why the time in the clinic becomes so important to making sure that you just not focus on the 5 questions you think you know to figure out if I can give the next cycle of treatment safely, but that all those symptoms ultimately can be addressed.
Can you hear me?
Yeah,
Okay.
sure. Hi.
Hi. When do you start counting the 5 years? From the first day you're diagnosed or after all the treatments are finished, which takes 2.5 years? So when do you start counting your 5 years?
So I don't count 5 years in follicular lymphoma. How's that for an answer? Because the 5-year mark I was referring to was about cure, right? So I measure it anyway. The way I think of when the clock starts ticking, to rephrase it a little, is when the treatment finishes. Okay, because when you're in the midst of getting chemotherapy, we don't know that the disease is really in remission or not. Now, when you look at some of the studies that have been done that look at outcome, it's a lot easier to measure things from either the date of diagnosis in a research study, because you know what date the pathology sample was reported, versus when the chemotherapy started. It's sometimes harder when you go back and review 1,000 patients' charts to really figure out where the treatment ended with precision. But in the clinic, when you're talking to a patient, you know when the treatment finished because you're usually having a discussion to say, here's how your scans look, this is great, this is the remission status, here's the plan for follow-up. And so to me, that's when it makes the most sense to start the clock.
Thank you.
Where are we going? I'll go there. Next. I can hear you if you want. Just go ahead.
I would like to address the issue of
back there.
drugs being approved in one province and not another.
Mm-hmm.
I was first diagnosed several years ago, and at that time, I think there were more than now, that were approved in BC. And I even contemplated moving to BC. And so I had heard in the last few years that there's a real effort to make things approved across Canada right away. And then today, a drug that you mentioned, I thought, oh, I want that. And you said, again, it's approved in BC. So can you address that issue, please?
Well, I can answer the question, I guess, as opposed to addressing it. But certainly what you may have seen in the papers in Canada at the moment is this idea of universal national care in terms of funding of drugs is a big issue in the country. The thing to remember, unfortunately, is that healthcare in Canada, the way things are designed, is a provincial decision. And thus, it's very difficult to say things from a national perspective. That being said, a national organization like Lymphoma Canada constantly advocates to ensure that the bar is the same across the country. Again, as a clinician, I think a patient I treat in Toronto should be able to be treated exactly the same way, whether they're in Quebec, Vancouver, anywhere else. It doesn't matter. But it is a quirk of the Canadian system because this is not a federal decision. That being said, increasingly, as drugs become more expensive, this funding window and how things get approved and then funded has frequently gotten longer. And so we know from having discussions with Health Canada and the people that ultimately provide funding decisions, everyone recognizes this and is trying to improve it. Okay, so that's where I can say I can explain why. We are making attempts to address it as clinicians and as advocates, but it's definitely a work in progress, and it's a frustrating one for us because we want it fixed yesterday, obviously. Okay, I'm gonna head up here for a second.
You talked a bit about Rituximab and some adverse side effects or other effects from being treated with Rituximab. One of the side effects that I know is low immunoglobulin after. And so if you end up, for example, I have to take Cuvitru or IVIG, have you ever seen it come back, your immunoglobulin levels?
Sure. Yeah, so again, the decision here, firstly, if a number is abnormal, do you have to fix it, right? And so there are a lot of people floating around who've had therapy that have a low immunoglobulin level and never have an infection. And in that setting, you don't need replacement. Again, IVIG is a blood product. It comes with additional risks. So again, you're weighing, is there benefit in reducing risk of infection versus the potential risk of getting a blood product monthly or what have you. B cells recover when the drug has been stopped. And so when it's out of your system a few months later, eventually B cells will start to grow up again and eventually start producing normal immunoglobulins. So over time, that will become less of a problem. And so at some point, well, it varies person to person, unfortunately. And so what's a prudent thing to do is, every year, every 6 months before the next prescription for IVIG is written, you get a level and you see if the immunoglobulins are improving or normalized. And then if that's the case, then you can consider stopping the drug or the support with the IVIG. Okay, we're going to shut it down. But again, thank you all for your attention, and I'll be around for a couple minutes, but I'm sure there's lots of other people that can answer questions. Thank you.